We are live.
A very good evening, everyone. Welcome to iFocus Online, lecture 283, number 24 in our Uvea module. Today we have with us Dr. Alok Sen, sir, from Sadguru Netra Chikitsalaya from Chitrakoot, talking to us on a very interesting topic, which is masquerades of uveitis, non-neoplastic. I invite Abhilasha ma'am to kindly introduce her to our audience.
Thank you, Dr. Shefali. A very good evening to all. It's my proud privilege to introduce Dr. Alok Sen, who is one of the stalwarts of vitreoretina and uveitis in India, and he's done some excellent work over the past 17 years. He has established the Department of Vitreoretina at Sadguru Netra Chikitsalaya, Chitrakoot 2006, which is a very busy retina clinic. He's the head of the department, and he has performed 4,000 videos of the 17. He has been a thesis guide to 10 DNB students and has trained over 25 fellows. He has authored 2 chapters and has numerous publications in peer-reviewed journals to his credit. We welcome Dr. Alok Sen, and we are eagerly waiting to listen to you, sir.
Yeah, thank you. Thank you so much for that kind introduction. And at the outset, I would like to thank Santosh sir for giving me this opportunity to share some of my work in uveitis. So I'll be sharing my screen now. Is the screen visible? And
yes.
Am I audible to you all?
Yes.
So again, good evening to all, and thank you so much for the opportunity. In next half an hour or so, I'll be showing some of the cases that we came across, and we had difficulty in diagnosis, and we had confusion whether these with dealing with uveitis or something else. At the outset only, I would like to say that I am now not a uvea specialist by any stretch of imagination. I am a retina, probably a self-trained retina person who does a lot of uveitis work by default. So whatever I will be sharing is some of my experiences in uveitis over last several years. As you all know, masquerades are something that are very intriguing. And the word masquerade originated sometime in 15th century from probably an Italian word mascara or a French word masquerade, meaning mask. And as per the Oxford dictionary, it means to hide one's identity or disguise as someone else. So uveitis masquerade are a group of ocular disease that mimic uveitis, but they are not really inflammatory in nature, or at least the primary disease which has led to uveitis is a non-inflammatory in nature. So the term masquerade syndrome in uveitis was first coined by Theodore in 1967 when he described a case of chronic conjunctivitis, which turned out to be a conjunctival carcinoma. And masquerades account for nearly 7% of patients referred to uveitis clinic. And they can be broadly classified as neoplastic and non-neoplastic masquerades. While most of the publications, they are focused on neoplastic masquerades, the non-neoplastic masquerades also contribute significantly, like almost 50% of masquerades could be non-neoplastic in nature. And some of these patients may harbor systemic conditions, which if not diagnosed or treated in time, may be life-threatening as well. So, and hence it is important that we also discuss non-neoplastic masquerades. So there are several diseases that can mimic uveitis. These are the list of some of the common entities which can be mistaken as uveitis, of which probably retinal degenerations, retinal detachment, central serous chorioretinopathy, and retinal vascular disorders. These are the common ones which are often mistaken as uveitis. So in next few slides, I will be showing 13 cases which we have seen in last several years and which were referred to us as uveitis, or we mistook them as uveitis only to later realize that we were dealing with something else. So my first case is this 24-year-old female who recently came to our OPD, and she had this diminution of vision in both the eyes. The left eye was PL positive and the right eye was, the vision was 2/60. As you can see from the anterior segment picture, the left eye showed a rin synechia, while the right eye, you can see that it is dilated and there are pigments over the lens capsule, which suggests that there is broken synechia. There were occasional cells in the anterior chamber, and both eyes had dense PSC with cortical cataract. The PSC was the cataract was denser in the left eye, and the fundus in the right eye was very hazy. And what you can see essentially is the posterior pole with normal looking disc, and the retina, at least the posterior pole, appeared attached. While what we could also see was pigmentary clumps in the anterior vitreous space, and that gave us a clue that we may not be dealing with something which was of uveitis or inflammation in nature. The pigment clumps in the anterior vitreous. So we did a B scan. What we found was the left eye showed a closed funnel RD, and the right eye also showed RD, but this was a localized RD in the infro. You can see from the B scan position, the infro nasal quadrant. So sometimes these peripheral RDs may be missed on a cursory posterior pole examination, and they may present with chronic anterior uveitis like picture. Now, this is the second case of a 72-year-old male who presented with a history of 10 days diminution of vision in the right eye, and the visual acuity was HM. And what you can see from the anterior segment photo, there was a presence of fibrinous exudate in the anterior chamber with posterior synechy at 12 o'clock and 11 o'clock. There was an intraocular lens in the sulcus, and the intraocular pressure was 9 millimeter of Hg. When we did the fundus examination, there was total retinal detachment. As you can see, there was a lot of vitreous haze, and we could also see folds of retina. So the retina was folded considerably, and when we did the B scan, what we also saw was the presence of these so you can see this, there were choroidal detachment as well. So this was an acute rhigmatinous retinal detachment with choroidal detachment. So retinal detachment with can mimic uveitis, because in chronic RDs, you can have a complicated cataract with posterior synechy. Sometimes in acute RD with CD, you may have anterior segment inflammation, and the CDs can obscure the breaks, and you may get confused with a exudative kind of retinal detachment in these cases. And also, sometimes there could be presence of cells which are photoreceptors with raised IOP, as in Schwartz syndrome, where you may confuse it with a viral anterior uveitis. The key is that usually these patients will not complain of significant ocular pain or congestion, and the presence of pigment clumps in eyes who have not undergone any surgery would suggest that there is retinal break, and this could be a retinal detachment. Now, this is my third case, who is a 27-year-old male who presented to us with diminution of vision for 6 months, and he was already receiving steroids elsewhere. The visual acuity in the right eye was 1 FFC, and in the left eye was 6/60. And what you can essentially see is these deep yellow lesions in both the eyes, right? And also there were pigmentary alterations in both the eyes in the posterior pole. And you can see this area of a small area, which was on clinical examination, which was elevated. And so this patient, we did a fluorescent angiography, and which in fluorescent angiography, what we can see is there were multiple PEDs. You can see these PEDs over here in both the eyes, along with stippled hyperfluorescence and some point leakages in both the eyes. So these were very suggestive of a central serous chorioretinopathy. And this, I'll go on to my next case, which is a 28-year-old male who presented with diminution of vision on and off in both the eyes since 2012. And he gave that he was recently put on steroid history, that he was recently put on steroid. The visual acuity in the right eye was 612, and in the left eye it was 624. There was presence of PSC in the left eye. And what you can see on the fundus examination is you can see these deep yellow lesions in both the eyes with pigmentary alteration, and there was neurosensory detachment, which was more evident on the OCTs in both the eyes, and there was subretinal hyperrefractive material in the left eye. So we went ahead and did angiography, and again the angiography showed pinpoint leakage in the eyes. What is very evident from the disc was absolutely quiet. So in both there was no leakage from the disc, and so this was again a case of central serous chorioretinopathy, which was mistaken as uveitis, posterior uveitis, and was treated with steroid. So we started tapering steroids readily, and we put the patient on Abhilasha 50 milligrams per day. And this is after a month where there is dilution of the fluid. And you can see on fundus autofluorescence also there is stippled hyperautofluorescence, which is very suggestive of a CSC. So multifocal serous detachment with subretinal fluid can be a presentation of typical CSC, especially when they are treated with steroid. These subretinal fibrin appear like choroiditis lesion, and usually they get treated wrongly as choroiditis. And the key is the absence of any healed scars, absence of cells in the vitreous or anterior chamber, and absence of vasculitis, which will help you in differentiating the two. And of course, if you do imaging, FFA, FAF, and OCT, that will help in distinguishing CSC from other inflammatory pathologies. Now, case 6 is a 34-year-old male who presented with history of painless reduction of vision in both the eyes, right eye more than left. And he also gave history of night blindness since childhood. And he was diagnosed as optic neuritis in the right eye and was treated with intravenous dexamethasone along with oral steroids. And when he presented to us, he was on 30 milligram of isilone per day. On fundus examination, what you see is there is a pale disc with blurred margin. There was gross arterial attenuation. The macula by and large appeared normal, but what you can see in the periphery is pigmentary alteration along in all the 4 quadrants. The picture was almost similar in the left eye, except for that the disc was not pale. There was gross arterial attenuation, which was even evident on in the left eye. This is an enlarged picture of the same. And on doing an OCT, what we noted was these presence of these cells in the vitreous. You can see this in both the eyes. And there was what you can see also is that the ellipsoid zone is preserved in the posterior pole, but as you move towards the periphery, you can see that there is loss of the ellipsoid zone in both the eyes. And the fundus autofluorescence classically shows a ring of hyperautofluorescence in the posterior pole, which is often seen in patients with retinitis pigmentosa and is known as Robinson-Holder's ring, which demarcates the area of viable photoreceptors and those where the photoreceptor is lost. And this corresponds to the OCT as well. You can see the ellipsoid zone, which is there in the posterior pole, while temporal to that, there is absence of ellipsoid zone. So retinitis pigmentosa, as you all know, is a progressive photoreceptor, a disease with progressive photoreceptor loss. It usually presents with night blindness, which is progressive, and progressive diminution of vision. And of the classic triad is waxy pallor of the disc, vascular attenuation, and pigmentary clumping. Now, the features that may mimic inflammation in these patients is presence of anterior segment and vitreous cells, which can be there in majority of the cases, vitreous cells. Pigmentary clumps along the vessels may sometimes mimic vasculitis, and presence of CME, which is seen in about 30 to 40% of these patients. Now, there is also evidence of inflammation in these eyes in the form of increased cytokine and chemokine levels, inflammatory cytokines and chemokine levels in these eyes. And there is a report which suggests that 0.2% of patients with retinitis pigmentosa may have a associated uveitis. Even wide field fluorescent angiography has shown peripheral vascular leakages in these patients. And there has been an association which has been known with Fuchs uveitis in these patients. So disc edema can be a feature of retinitis pigmentosa, and it could be because of optic nerve head drusen, or sometimes these patients may develop non-arthritic anti-ischemic optic neuropathy, as in the present case, or they may also develop optic neuritis. And inflammation is usually due to the neuronal damage in these eyes. So retinitis pigmentosa can sometimes be mistaken as uveitis in atypical presentations. And now my seventh case is a 24-year-old male who presented with diminution of vision in both the eyes for 6 months. And he also gave a history of night blindness in childhood. He gave history of left eye redness 1 year back, for which he took treatment elsewhere. The intraocular pressure were within normal range in both the eyes, and the vision was 624 in the right eye and 2/60 in the left eye. And what you can also see that there was a broad braced posterior synechia in the left eye with some amount of pigment dispersal over the anterior lens capsule. Now, the fundus, to our surprise, showed a normal appearing optic disc. There was the presence of these yellow clumps of deposits, which were more predominantly seen in the posterior pole along the arcades, which was seen more in the left eye as compared to the right eye. In the periphery, there was presence of these nebular pigmentary lesions and sclerosed vessels. You can see over here also the sclerosis of vessel. The macula, by and large, appeared normal, although these deposits, they were encroaching towards the fovea in the left eye. Now, the OCT showed that these lesions were essentially sub-RPE, as you can see here. And you can also see that there was lamellar thickening, that the retina was a little bit thickened, and there was some amount of fluid, intraretinal fluid, which was there. In the right eye, the photoreceptors, at least at the fovea or near the fovea, appeared to be there with the intact ellipsoid zone, while in the left eye, there was a total loss of photoreceptors. You can see that there was the ellipsoid zone was completely absent. We were not sure what we were dealing with. We thought that this could be retinitis pigmentosa with associated uveitis, pan-uveitis. We were not sure about the cause because this did not fit into any of the uveitic entity. could it be a vascular pathology, because there was a lot of exudation. And we did a battery of investigation. Everything came out to be normal. The ERG was flat in both the eyes. And while we were investigating the patient was lost to follow-up and came back after 2 months. And this was the picture. The left eye had developed neovascular glaucoma. And so we were really not sure what we were dealing with, but we thought that this could be some variant of retinitis pigmentosa. And so we did a whole genome sequencing. And what we found was there was a mutation in the CAPN5 gene. And this is related to what is known as autosomal dominant neovascular inflammatory vitreoretinopathy. So this is a rare autoimmune uveitis with inherited vitreoretinopathy, and it is caused because of mutation in CAPN5 gene, which codes for a cysteine protease. And the hyperactivity of this protease leads to photoreceptor degeneration or loss. And this can be confused with the non-specific uveitis, retinitis pigmentosa, or even proliferative retinopathies. So very interesting case which came across, and we were not sure, and only after doing whole genome sequencing that we could make the diagnosis. My 8th case is a 53-year-old male from UP who presented with diminution of vision in the left eye for 10 days and right eye for more than a month or so. The patient was a known case of diabetes for 2 years, and he had undergone a left eye cataract surgery about a month back. The vision in the left eye was 624, and the right eye had a mature senile cataract. So you can see the left eye picture. What you see is these granular yellow lesions along the vessels in both the eyes, and there was with a center which had a lot of hemorrhages in the center. And see in all the 4 quadrants, you had this picture of deep yellow lesions with central sparing and hemorrhages in the center. So we thought initially on a cursory look that we might be dealing with some kind of retinitis. You can see a picture of CMV retinitis in the inset. And so we thought that we might be dealing with some kind of retinitis. But I'll come to that later. So we did an FFA, and interestingly, the FFA showed capillary non-perfusion areas in the center of the lesion, and in the late phase there was staining at the edges of these capillary non-perfusion area, which corresponded to the areas which showed those deep retinal whitening. The OCT of the eye did not show evidence of retinitis. As you can see here, the lamellar arrangement of the retinal layers were still there. There were some hyperreflective dots which was present, and the macula showed a neurosensory detachment with intraretinal fluid. So we were sure, not just because of the OCT, but what you can see also that the vessels which were traversing these areas of deep retinal lesions were also very clearly demarcated. So we were sure that we may not be dealing with a case of retinitis. So we decided to operate the other eye, and the other eye also showed similar lesion, but of course to a lesser extent. And then the labs report came, and we found that this patient had a severe dyslipidemia. So sometimes these patients with metabolic syndromes, especially diabetes with severe dyslipidemia, may present with leakage of lipids not only in the anterior chamber, but extensive leakage or exudation in the retina, which may at times mimic uveitis. And it's a red flag for severe systemic disorder. So you have to be aware of these kind of presentations. The next case is a 25-year-old male who presented with diminution of vision, sudden diminution of vision for 20 days. He gave history of fever 2 months back. Now, this is something, sometimes history may be misleading. So this is a case where the history was a little misleading to us. The visual acuity was 6.6 in the right eye, and the left eye it was 6/36. The anterior segment was quite, the posterior segment was, there was no evidence of any cells. The fundus, both eyes had disc edema. You can see clearly here, the disc margins were blurred, there was edema. And there was presence of exudation in the macular area in both the eyes. You can see the macular fan-like appearance in both the eyes. There was a little bit of tortuosity of vessels, but not very evident. But what you can see, these deep yellow lesions, which were scattered in both the eyes, right? And what in the both the eyes, and this, and what you can also see, there were focal areas of neurosensory detachments. Now, this patient was shown to me as a case of post-fever retinitis, which was resolving. And what essentially was because they had the lesions in the posterior pole, which was deep retinal, were mistaken as choroiditis, and the lesions which were like this cotton wool spot, which was there in the supratemporal arcade in the right eye, were mistaken as retinitis. So sometimes, and just to show an analogy, this is a patient of Mutes where you can see multiple white lesions, deep retinal lesions, and this these can be confused with uveitis. Now, when we did an OCT, what we saw that there was a little bit of fluid in the right eye, subretinal fluid in the right eye, while in the left eye there was significant subretinal fluid along with intraretinal fluid. Now, the FFA showed there were just point leakages corresponding to those areas of deep retinal yellow or deep retinal lesions. And there was little bit of disc leakage more in the left eye than in the right eye. And what you can also see, these streaks of hypofluorescence surrounded by hyperfluorescence. You can see more clearly in the left eye, and there were areas of hypofluorescence, ring of hyperfluorescence with central hypofluorescence. So these are very characteristics of hypertensive retinopathy. And the blood pressure of this patient was 200/120. He had the lab showed that he had some amount of renal failure, and the urine also showed significant protein and RBCs. So accelerated hypertension is defined as an acute rise in BP with a target organ damage. And majority of these patients are of essential hypertension. However, younger patients, as in our case, may have a renal or parenchymal or renovascular disease, and sometimes it can be a feature of preeclampsia or eclampsia. Now, in accelerated hypertension, you can have retinopathy, choroidopathy, or optic neuropathy. Now, these choroidopathies, or what we saw in our case were Eschenich spots, and this can be mistaken for multifocal choroiditis. And these are usually because of fibrinoid necrosis of the choroidal vessel arterioles. Similarly, the retinopathy, which presents as cotton wool spots or superficial retinal hemorrhages, can be mistaken for retinitis. And optic neuropathy, which is usually because of axonal stasis, leads to disc edema. So these are some of the features which may mimic the retinitis, choroiditis, or posterior uveitis. So we should be aware of these classic lesions that are there in hypertensive retinopathy. Now, this is a 27-year-old male who presented with blurring of vision in the left eye. He had an history of trauma to the left eye, after which he underwent cataract surgery in the left eye about 15 years back. The visual acuity in the left eye was 6/18, improving to 6/6 with the correction, and the intraocular pressure was 27 millimeter of Hg in the left eye. And what you can see here is there was endothelial pigmented capes, along with diffuse cells, pigmented cells in the anterior chamber. The fundus essentially was normal, except that there were some presence of some exudation inferiorly. However, there was no evidence of any vasculitis or any other scars, choroidal scar or chorioretinal scars, or any cystoid macular edema at the time of presentation. We did an UBM, and what it showed was that one of the lens haptic was touching the iris. The lens was slightly tilted, and one of the haptic was touching the iris, and this gave us the clue that this could be a case of UGH. So uveitis glaucoma ephema syndrome, as it is known, is a rare complication of cataract surgery, and it is usually because of misplaced IOL, or sometimes if an foldable acrylic IOL is placed in sulcus, it can also lead to UGH syndrome. And it presents with a triad of uveitis, raised IOP, and hyphema. Now, it can also present with iris atrophy, fine pigmented KPs, with haze and anterior segment cells, and may be confused with viral anterior uveitis sometimes. And if it presents with vitreous hemorrhage, then it is known as UGH plus syndrome. As you can see, this is one of our case who presented with a displaced or misplaced SFIL, and you can see that the amount of hemorrhage, anterior segment hyphema, and vitreous hemorrhage it has caused. Now, the treatment is to surgically remove the IOL or replace the IOL, and you can also medically manage with topical steroids or anti-glaucoma medication. But the definitive treatment would be to remove the IOL, which has led to this condition. Now, the next case is a 30-year-old female who presented with gradual diminution of vision in both the eyes for 2 years, and there was no other systemic history, hypertension, diabetes, or any other. The fundus examination in both the eyes showed a large disc cupping along with tortuosity of vessels, and you can see some amount of bite without pressure in both the eyes in the periphery. And what is evident more clearly in the left eye is this presence of exudative retinal detachment. It was also present in the right eye, and some amount of pigmentary disturbance overall in the posterior pole. You can see this pigmentary alteration which was there in the posteriorly. So OCT showed the RPE was undulating. However, the choroid was not that thickened. But you can see even on the Swepsos OCT, there was a considerable thickening of the sclera. And there was presence of subretinal fluid. There were no cells in the vitreous awaiting the retina. Now, this is the B scan, and it also shows a thickened RCS along with an exudative retinal detachment. Now, on FFA, there were numerous pinpoint leakages, and in the periphery, you can see this staining of the vessel because of the exudative retinal detachment which was there. Now, this was a case of UES, which is uveal effusion syndrome, and this patient underwent sclerotomy in both the eyes, and post sclerotomy you can see that there was a resolution of the RP undulation and the fluid. Now, uveal effusion syndrome is basically collection of transudate in the choroid and the suprachoroidal space, and sometimes in the subretinal space, leading to exudative retinal detachments. Now, this is primarily due to compression of the vertex pin because of a thickened sclera or an abnormal sclera. And there are of two types, one associated with nanophthalmos, and type 2 is idiopathic. Now, usually they present with choroidal thickening, and the thickening is more profound in the periphery, and at times it pushes the aura towards the center, and this leads to an easy visualization of the aura. That is one of the signs of uveal effusion syndrome. There could be exudative detachment because and with shifting fluid, because the fluid which is subretinal fluid is of high protein, has a high protein concentration. It shifts because it's heavy, and there can be RP alteration. These the syndrome can mimic inflammatory condition like VKH, and see the OCT picture of a case of VKH in the slide, or posterior scleritis, or sometimes sympathetic ophthalmia. But absence of inflammatory cells and thickened sclera can give you clue towards evil effusion syndrome. The management is basically to decompress the vortex vein or sclerotomy, as we did in our case. This is a case, a 16-year-old male who had history of trauma to the left eye 6 months back. He presented with pain, redness, and diminution of vision in the left eye for 1 month or so. The vision in the left eye was PLPR, and the intraocular pressure was 6. And what you can see here is that there was presence of pigments over the anterior lens capsule, along with some posterior synetia, and if you see carefully, there was a hole in the eyes. So this gave us a clue that he may be dealing with something, because he gave history of trauma. There was a hole. He may be dealing with intraocular foreign body, may present at times with chronic uveitis-like picture. And when we did B scan, he had a retinal detachment, and there was a presence of a retained intraocular foreign body. Now, sometimes intraocular foreign body may be missed and may lead to inflammation and mimic uveitis. Even metallosis, sidrosis, as in our case, can mimic uveitis, and you should have a very high index of suspicion in these cases. And sometimes you would be surprised to find an intraocular foreign body in the angle, or sometimes even just behind the iris, or at the level of the ciliary body. So you have to have a very high index of suspicion in these cases to diagnose an intraocular foreign bodies, especially if they are presenting with chronic infection. This is my last case, and this is a 42-year-old female who presented with diminution of vision in both the eyes, with brain redness and swelling both the eyes. She gave history of headache for 6 and was diagnosed as migraine elsewhere, and was put on topiramate 50 milligrams since 7 days. The visual acuity in both the eyes was 3/60. There was shallow anterior chamber, as you can see here, diffuse haze of the cornea with DM folds. The lens was essentially clear, but the IOP was 50 millimeter of Hg in both the eyes. So we thought that we were dealing with topiramate toxicity, and we stopped topiramate. We started the patient on oral steroids as well as topical steroids, and our glaucoma colleagues, they had started the patient on Diamox along with the anti-glaucoma drops. Now, the vision remained low, and after 3 days of treatment, there was increase in anterior segment inflammation. The IOP was now 11 millimeter of Hg, and the patient developed 360-degree choroidal detachment. So we stopped all the medication, and we made a diagnosis of topiramate associated drug-induced uveitis, and this was probably accentuated when we gave the patient Diamox, which is also a sulfonate group of drug. So, and after we had stopped all the medication and put the patient on steroids, the patient vision improved to 6/18. There was still evidence of disc edema and choroidal edema, but the choroidal detachment had resolved. Now, is present with either local or systemic application of medicine or even vaccines. Now, with COVID vaccination, we have come across cases of anterior uveitis, posterior uveitis, retinitis. We reported a case of retinitis we presented after COVID vaccination. So vaccines are an important there are association of uveitis with vaccines as well as certain medications. Now, the incidence is rare, although it could be because they are not reported, or it is difficult to establish an association between a drug and uveitis. Naranjo gave this causality criteria, and it has 10 questions and scores, and the maximum possible score is 13, and any drug which scores more than 9 has a high chance or probable of a drug adverse drug that the adverse drug reaction could be because of that drug. Now, uveitis several drugs can cause uveitis. Of late, we have seen reports of anti-VEGF, especially brolucizumab, which was associated with vasculitis, and many of the anti-VEGFs also do cause little bit of anterior uveitis as well. Sulfonamides are again drugs which are known to cause acute angle closure glaucoma or uveitis, pan-uveitis like picture, as in our case of topiramide usage. So to summarize, non-neoplastic uveitis masquerades are usually sometimes can be of diagnostic challenge. You should be accustomed of picking up the characteristics patterns in these cases, and they usually do not fit into any of the described uveitis pattern. Absence of inflammation in these cases is the key to diagnose non-neoplastic uveitis. But as I've shown, some of these patients may present with uveitis as well. And of course, multimodal imaging will help you in making the diagnosis in some of these cases. So at the end, I would like to thank all my fellows and colleagues in the department who have collected these cases for me, and Professor Amod Gupta, whom I cannot thank more, because without his guidance and his motivation, I would not have taken up uveitis seriously. Thank you so much for the opportunity once again, and I will be happy to answer some of the queries.
So took us through some very good with excellent documentation, and I'm sure the postgraduates will really benefit from this talk. And I will go through it again to absorb all the information that you gave us today. So there are very few questions. First is, clinically, how can we differentiate siderosis from chronic anterior or intermediate uveitis?
Yeah, so since the siderosis usually would present with pigments over the anterior lens capsule, as I had shown in one of my case where we have. But having said so, there can be some amount of inflammation as well. So, and usually it is about recognizing a pattern. So there would be a history of trauma. There would be some evidence of trauma in the eye, as was shown in our case also, where there was a hole in the iris, which suggests that there could be some foreign body. The pigments are usually diffuse over the anterior lens capsule, and unlike pigments which are there of broken synechia, which are typically ring pigments, they would not be there. There would not be KPs like what we see in anterior uveitis. There would be no pigmentation or diffuse pigmentation in the endothelium cells as well. There is never a very severe anterior segment inflammation like fibrin, or unless until it is associated with because these patients are usually chronic and they present late to us. So acute phase intraocular foreign body may sometimes present with endophthalmitis, and it can present with hypopion, fibrin and all. But history of trauma is very important. History of trauma and signs, telltale signs of trauma, like hole in the iris or some effect in the iris. And of course, imaging will help in these cases. The typical pigmentation over the anterior capsule, which is brownish pigmentation, coin-shaped pigmentation over the anterior capsule, is very classic of siderosis.
Yes, sir. Thank you, sir. And one more point that we have seen very commonly, sometimes students tend to mistake a Krukenberg spindle also. So the Krukenberg spindle that you see in glaucoma. So many times, they
That
write
can be mistaken as KPs.
it is fine KPs, and so you have to. It is a spindle shape, and it is vertical. It's not like an arched triangle, and that should PG should not get with that. So going on to the next question, sir. Okay. Can COVID vaccination present as a masquerade?
So there have been a lot of reports post-vaccination where we have also reported one case where post-COVID vaccine there was a retinitis. There are reports on anti-uveitis. Now vaccines are known to incite inflammation, or sometimes it can also activate herpes in the eye. But as such, we don't have a conclusive evidence that COVID vaccine is associated with uveitis. We need more evidence on that to say with certainty that COVID vaccination lead to. But there are reports, and we have also reported, we have also come across anti-uveitis. Whether they are true associations or just a coincidental occurrence, we really don't know. And there, not only COVID, we have these reports with other vaccines as well. So we are not sure, but yes, vaccines can lead to adverse drug reactions, and uveitis is one of the associations of vaccines, which is at present with COVID vaccination, it's not well established.
Yes. So if a patient gives history of recent vaccination and comes to you with inflammation, do you routinely do D-dimer and COVID antibody levels to?
So this we did in some of our cases who presented with uveitis when we had this large-scale vaccination going on. We had a patient of retinitis, we had a patient of anti-uveitis, we also had a patient who came with posture like retinopathy, and we did all kinds of tests. But believe me, everything came out negative in all the patients. And only thing that was positive was a temporal association between vaccine taken and the presentation. We really don't know. We have not yet had a patient whom we challenged again with another vaccine like second dose or booster dose, and whether the same thing occurred again. We have not come across such a patient. But yes, we have to be vigilant. Usually post clinical trials, when the drug is in the market, and this is known as post phase 4 trial, where you look for adverse reactions which may not come across during the clinical trial. So you need to be vigilant, and there have been reports, and I'm sure there would be more. But as I said, it is very difficult. We did all the tests because, see, one thing is you want to know whether it is COVID or it is vaccine or what is going wrong, or what we are dealing with any other uveitic entity. So we extensively investigate for uveitis to rule out other uveitis as well. So we did, in our case of viral retinitis, which we published, we also did a vitreous tap, and we could and PCR showed that there was HSV reactivation. So we don't really know what all we should do in these cases. But yes, we need to be vigilant. Of course, with the vaccination program going down, we are no more seeing, and even the COVID epidemic is now quite down. So we are not really seeing. But we have also seen some patients of retinitis, like post fever retinitis or epidemic retinitis, that we often see post COVID as well, or post vaccination as well. So yes, something which is intriguing, but we really don't have answers as yet.
Yes. So one question which I would like to ask, and I think PGs also should know. So sometimes the dehemoglobinized blood, in which is hemorrhage, that looks yellow, and sometimes that might be confused when people are just learning. So how to differentiate from snowball opacities that you see?
Yeah, so usually deep hemoglobinized blood is usually in clumps, inferiorly in clumps, and there would be some evidence of fresh and old blood. So it's a mix of fresh and old blood, but at times it can be confused. And if you are not sure, you can do an FFA. That's a very easy way to rule out neovascularization. But the classic these snowballs are usually around, they are inferiorly located, they are discrete. Very rarely they can be clumped together, as in tuberculosis. But there would be evidence of peripheral vasculitis. There would be evidence of some kind of scarring. There would be evidence of peripheral vascular leakage on FFA. So there would be evidence of anterior segment inflammation, spillover anterior segment inflammation as well. So it is a collective picture rather than just one way of looking at things. So, and at times you can have both together, like vasculitis presenting with blood as well as inflammation. So it's sometimes very difficult to judge whether it is the vessel that the bleed is there, or whether it is the clotted or dehemoglobinized blood would be in clumps rather than those discrete. That is what I feel.
Yes, they are large irregular masses. They appear like large irregular masses, unlike snowballs, which are nice and round and look like pearls in the witches. One more thing, Exert spoke about vasculitis. Sometimes we also see patients with raised serum homocysteine. So they also might present with vascular occlusion. Would you like to say something, sir, regarding that?
So one way of differentiating vascular occlusion, like branch vein occlusion, from occlusions because of vasculitis, which we see often in TB or sarcoid, is to look where the occlusions are. If the occlusion is at the level of AV crossing, and it is more likely to be because of vascular cause, as in homocystinuria, where you have atherosclerotic changes in the artery which compresses the vein and causes the occlusion. While in vasculitis, it is more often they would be multifocal. There would be more than one vein that would be occluded. There not necessarily it would be the AV crossing, right? And it is often you see that there would be occlusion in two different areas in the periphery. So these are some of the clues that can tell you that this is not a vein occlusion and it may be a vasculitis.
Yes, sir.
Along with even with vein occlusion, sometimes with acute occlusions, there could be some amount of spillovers. Sometimes there is hemorrhages which can leak through the ILM and cause a little bit of vitreous hemorrhage or vitreous cells. So sometimes it can be confusing as vitritis. But yes, one is that the location of the occlusion in vein occlusions is at the level of AV crossing, while in vasculitis it can be anywhere. More often it is in the periphery.
Yes, yes, that's a very important point that sir has said, and I hope the PGs have paid attention to that. And so you also showed a very nice case of hypertensive retinopathy. So that cotton wool spots and those things also should raise a bell. So you are saying something?
Yeah, so hypertensive retinopathy, of late we have seen at least 4 cases of hypertensive retinopathy, and all the 4 cases were referred to me as cases of uveitis. And so it is very important to look for the evidence of choroidopathy in these eyes, because choroid gets involved earlier than the retina, because the autoregulation is present in retina, which regulates a little bit, which can manage with accelerated hypertension to a certain level, while the choroid gets involved earlier. So sometimes these patients may just present with, and not even cotton wool spots and all, they can just present with disc edema and those deep retinal lesions that can be confused with choroiditis. Of course, they don't have inflammation, and usually choroiditis is like you will have fresh lesions and old heal lesions in choroiditis. Unlike in accelerated hypertension, these all will be coming up together.
Yes, so one more question. So rifabutin induced intraocular inflammation, is it a masquerade or is it a true drug-induced uveitis?
To be very frank, to be very frank, I am not sure about it. But most of these drug, see, a drug, if you talk about uveitis masquerades, as I had said in the definition itself, it could be non-inflammatory conditions which mimic inflammation, or it could be conditions which are not primarily inflammatory. So the trigger is not an inflammatory condition and still can lead to inflammation, like retinal detachment. It's not that it is not a true inflammation. You still have posterior synechial cells and all, which is true inflammation, but but the trigger is not actually the inflammatory condition. So maybe these drugs also, as I showed a case of topiramate toxicity, which topiramate is itself can lead to inflammation, pan-uveitis. Now the trigger is the drug, but which is a non-inflammatory condition. So the thing is, it can still be a masquerade, but the trigger is a non-inflammatory condition.
Yes. So thank you so much, sir. We are done with all the questions. And thank you so much for sharing your knowledge today and for your time and effort in teaching all the students here today. And this will also be later there on YouTube, I think, and the students can listen to the talks again. So with that, I'll close for today and over to Shefali.
Thank you so much, ma'am. And thank you so much, Alok sir, for taking out your time for this very interesting topic and for summarizing so very well with all the case scenarios and all the pictures and documentation. Next, we meet on February 24th, which is Friday. Then the topic is neoplastic uveitis masquerade syndromes by our very own beloved mentor, Dr. Santosh Nawar sir, who is the brain and force behind iFocus. So I'm really looking forward to that and hope you all also make it to the lecture because you wouldn't want to miss it. Also about the iFocus Physical, we are kickstarting the week-long iFocus Physical program in New Delhi on February 26th. So those who have registered, see you all there. Thank you so much, everyone, and a very good night.
Thank you and good night. Thank you.
Thank you, sir.
Thank you so much, sir. It was really pleasure listening to you.
Bye, ma'am. Thank you so much
Bye.
again.
Bye, Shefali. Thank you.